Hi, I'm Dr. Mark Fraiman. Today's medical tutorial is on what causes pancreatic cancer. In order to understand what causes pancreatic cancer, we have to understand the cell cycle of a normal pancreas cancer cell. Keep in mind that all cells do not divide at the same rate. Intestinal cells have the highest turnover rate. Pancreas cells are somewhere in the middle. The cell cycle of a cell starts with G0, which is the resting phase. Cells right before replication enter G1, which is essentially a checkpoint. And during this checkpoint, there are enzymes. Some of them are called CDK, some are tumor suppressor genes. Anyway, there's a whole list of enzymes that make sure the cell is ready to undergo DNA synthesis. At this point, the DNA actually replicates. Cells then enter G2 phase, which is a second checkpoint, before entering the M phase, or mitosis, which stands for cell division. So this cell cycle is a very complex process with two checkpoints in it. And these checkpoints are important because anywhere along the line during these checkpoints, if an error is recognized, the cells can undergo apoptosis, which is programmed cell death. And certainly that's the more favorable situation if there's a mistake, because if the cells kill themselves or have apoptosis, then you're not going to get a cancer cell. So why are there disruptions in this cell cycle which lead to abnormal growth and cancer? Well, the first type of genes that work at these checkpoints are called tumor suppressor genes. And in pancreatic cancer, there are a host of tumor suppressor genes which have been inactivated. And it's this inactivation of these genes which causes the cells to essentially go awry. So these tumor suppressor genes can be subcategorized into gatekeeper genes, which work in the beginning of the cell cycle. P53 is an example of a tumor suppressor gene that is inactivated in pancreatic cancer. There are caretaker genes, which are important during actual cell division. And then there are what's called landscaper genes, which are more important in the microenvironment. Tumor suppressor genes that are inactivated are the P16 gene, the P53, and then there's one gene called SMAD4. These all have variances anywhere from 25% to 75 and 80% in pancreatic cancer. The next type of genes that are seen to be abnormal during cell division are oncogenes. Oncogenes are derived from proto-oncogenes and are important. These proto-oncogenes are important in promoting cell growth. Transformation to cancer involves really alterations or mutations in the proto-oncogenes to subsequently form these abnormal oncogenes, which caused the oncogenes can cause a continuous drive for cell replication in an abnormal way. In other words, the cells just begin dividing unchecked continuously. So the progression model for pancreatic cancer basically states that it's a combination of the oncogene and a combination of the oncogenes and tumor suppressor gene inactivations that occur in a sequence and which leads ultimately for a normal cell to become dysplastic, then carcinoma in situ, and then invasive cancer. So in this progression model, some of the genes we spoke about, KRAS is an oncogene which initially causes cell division to go haywire. P16 is a tumor suppressor gene, which we spoke about, which is inactivated in pancreatic cancer, as well as P53. The BRCA2 gene is seen in familial cases of pancreatic cancer, which occur in about 10% of cases. So 90% of pancreatic cancers have mutations in KRAS, which is the oncogene we spoke about, as well as the tumor suppressor gene P16. 50% have inactivation of these tumor suppressor genes, and then 10%, or the familial variant, have a mutation called BRCA2, which is also a tumor suppressor gene. So what causes these pancreatic cancer mutations is unknown. We do know that cigarette smoking is implicated in causing mutations, genetic mutations. In pancreatic cancer, there may be a threefold increase in patients with a heavy history of cigarette smoking. Exposure to organic solvents is common. Chronic alcohol intake is common. Coffee has been implicated. A history of chronic pancreatitis with multiple attacks over a lifetime is also a predisposing factor, as well as diabetes. As I mentioned before, 10% of these cases are actually familial, and most of the familial involve the BRCA2 gene. In the future, hopefully there will be molecular markers used in screening. For example, the KRAS oncogene, which I mentioned, which is present in 80 to 90% of pancreatic cancers, may be able to be used as a screening method of either samples of pancreatic juice, duodenal fluid, or stool samples, for example. Serum screening for KRAS mutations may be possible in combination with CA19-9 and other surface glycoproteins. The other tumor suppressor gene that we mentioned, P53, may also be promising as a screening tool, again in patients' pancreatic juice or stool specimens. In summary, pancreatic cancer is caused by a series of mutations in enzymes and proteins that are abnormal or mutated in the process of controlling cell division. It is a multi-hit and progression theory where multiple changes and mutations in the proteins have to occur, and pancreatic cancer is not formed overnight, but it is formed in a progression model where cells change characteristics from metaplasia to dysplasia to carcinoma in situ before becoming an invasive cancer.